I'm going to let Dr. Van Perry introduce the topic because wants to tell a personal story.
Sure. So Dr. Green's topic this morning is an extremely relevant one, and as a parent, I can say the concern about drowning is one of the biggest that parents have, and the biggest fears, especially if you own a swimming pool. And so that's one of the reasons that a lot of parents will say, I'm not looking for a house with a swimming pool because of exactly the fear of this. When I was a resident, as a second-year resident in the PICU, a little girl was brought in overnight. She had just driven in with her family the night before. She's 3 years old. A little blue-eyed blonde girl named Julia, which was the same name and phenotype as my own at the exact same time. And this little girl had gotten to Grandma's house. The family was exhausted from driving all night, and parents fell asleep on the couch. The little girl wandered out into Grandma's swimming pool and drowned. And it was just absolutely devastating for the family, of course. But as a parent and a resident, seeing this child whose face I can still see, you know, it's very impressive, very scary as a parent. And we've had plenty of drownings around this area of the state of kids, even teenagers, who didn't know how to swim. And that's really one of the things from a public health perspective, we as pediatricians and physicians and all those really have to encourage that kids learn how to swim as early as they can. And there are public programs, there, you know, obviously if you have means, you pay for somebody to teach your child to swim, but teaching kids to swim is absolutely essential. So with that.
Thank you. Can everybody hear me okay? Okay, I know it's middle of the winter time, but we still see drownings year-round, mostly predominantly in the summertime, spring and summer, but we do see it year-round. Of note, we did have one come in the PI last night. There's a 16-month-old in the bathtub. So we do see this. This is a significance of importance. I have nothing to disclose. So the objectives today, we're going to discuss the worldwide and national statistics of drowning, how big of a problem this is. Identify risk factors and groups that are at risk of drowning. Review the pathophysiology of drowning. Establish predictors for outcome of drowning, and explore the role of the pediatrician in drowning prevention. So what we can do in the clinics and seeing patients that can make a big difference in prevention. Just a little bit of historical background, some information I ran across when I was researching that I found very interesting, maybe to wake y'all up this morning first. The Royal Humane Society, 1814, published Rules for Recovery of the Apparent Drowned. So here's a poem, or they wrote it in poem form, but these are the rules. I'll read it to you. When in the stream by accident is found a pallid body of the recent drowned, though every sign of life is wholly fled, and all are ready to pronounce it dead. More patient thou, with ardor persevere, 4 hours at least the generous heart will fear. To quit its charge too soon in dark despair, will ply each mean and watch the effect with care. For should the smallest spark of life remain, life's genial head may kindle bright again. That was in 1814. One other historical background is published in 1824, the Glasgow Mechanics magazine and Annals of Philosophy republished those rules from the Humane Society, but they had some other statements that I thought was quite interesting and recommendations for how to treat the drowned. They stated that there was actually no record of person that had been recovered from drowning who had been in the water greater than 45 minutes had survived. But they said you still have to attempt to resuscitate. So what they recommend, they made some recommendations, which in 1824 I thought was quite interesting. For resuscitation, what they'll do is do quickly, which is still relevant today, right? Bring to the nearest house. Okay, of course they found people in streams and ditches and things like that. Warm slowly. They said to introduce a pipe into the nostril, inflate lungs, and repeat until life appears, which I thought was quite interesting. Place hot bricks to the chest, palms, and soles to continue the warming process. Warm enema to warm internal parts and restore the motion of the intestines. So this is what they were doing in the 1800s. Also published cautions, so to be careful when bathing rivers and canals. Don't go too far from the shore. move victim to recovery house as soon as possible. And what I also thought was interesting is how to handle the body once you recover the body and you take it to this house. It says, handle the body carefully. Do not put the body over the shoulders and hang the head downwards or upside down, and do not drag the body along the ground, allowing the head to drag along the ground. So I just thought it was just interesting, some things I came across. So first we'll talk about what is the definition of drowning. It is the process resulting in primary respiratory impairment from submersion or immersion in a liquid medium. So we no longer use the previous descriptions. We no longer use near drowning, wet and dry drowning, secondary drowning. They wanted to make it, to simplify things for statistics, reporting, things like that. So we just call it drowning now. So look at the World Health Organization statistics. So it's the third leading cause of unintentional injury or death worldwide, and it accounts for 7% of all injury-related deaths. So there's an estimated 372,000 deaths per year worldwide. And children and males are those with increased risk of access to water are those at most risk. As far as the CDC statistics for the U.S., from the year 2005 to 2014, there was an average of 3,536 fatal unintentional drownings annually, and that does not include boating accidents, which averaged to about 10 deaths per day in the U.S., which is quite a lot. 1 in 5 of those deaths are children that are 14 and younger. For every child who dies, there's another 5 that receive care in the emergency department for non-fatal submersion injuries. And it is the second leading cause of death from unintentional injuries in children aged 1 to 14, only secondary to motor vehicle accidents. So it's a very significant problem. More than 50% of drowning victims that are treated in the emergency department require hospitalization. And then the non-fatal injuries, if you survive a drowning, you still can have problems with long-term disabilities, memory problems, learning problems, and permanent loss of basic functioning. So it's a significant morbidity if you survive. So talk about risk factors. Who are those patients that are most at risk of drowning? Some studies quote males. Nearly 80% of drowning victims are male. Age 1 to 4 years old. Drowning is secondary only to congenital abnormalities. Age 1 to 14, unintentional injuries is the second leading cause only to MVCs. We already talked about that. The other issue, the other big risk factor is minorities. African Americans are higher across all age groups. And especially the 5 to 19 year age group, they have a 5.5 times higher risk of dying from drowning. The 11 to 12 year age group has a 10 times higher risk of drowning rate, which is pretty significant. So factors that influence risk, okay? So lack of swimming ability, lack of barriers, so like no fence or gate around a pool. Lack of close supervision, which is probably number 1. Location, so the age group and the location vary. So less than a year old, it's usually bathtub, buckets of water, things around. 1 to 4 year old, the number 1 place is home swimming pools. So the toddlers is home swimming pools. And the interesting thing is, it's most of the patients that drown in home swimming pools, it's within the first 6 months of exposure. So it's like somebody traveling and go to somebody's house that has a pool, or it's you move to a new house with a pool, or you get a pool installed. It's most of the time it's within the first 6 months. Greater than 4 years old, especially teenagers, it's usually natural water settings, lakes, rivers, oceans. Failure to wear life jackets. 2010, 70% of boating deaths were due to drowning, and 88% of those patients were not wearing life jackets, which is amazing to me. Alcohol use has been associated, especially with teenagers and adults. 70% of deaths associated with boating, water recreation involved alcohol. And that's 1 in 5 boating deaths involved alcohol. The other interesting thing is tourists have a higher risk of drowning than locals. So you have all these people going on vacation, these nice ocean vacations and things like that. So tourists are actually at a higher risk, which makes sense. The other thing is there's two medical conditions that put you at higher risk of drowning. A seizure disorder is a huge one. It is the most common cause of unintentional injury or death in a seizure patient is drowning. And the bathtub is actually the highest site of drowning risk. Epilepsy has a 10-fold increased risk of submersion injury. And actually, I found in literature it's anywhere from 10 to 20 times higher risk. The other thing is, the other medical condition is long QT syndrome. Swimming is thought to be a arrhythmogenic trigger for arrhythmias. So that was interesting. And some of the patients are thought to have underlying long QT or not diagnosed yet, long QT. They dive in the water, have a arrhythmia, and that causes them to drown. Okay, talk about the pathophysiology of drowning. So what happens when somebody drowns? Most of the things you see is somebody's waving, yelling, hey, help me, I'm in trouble. That's not the case. It's silent. Okay, most drownings are silent. They don't shout or wave for help. Most just disappear underwater in less than a second. No distress, leaving only a short ripple of water on the surface. The normal instinct drowning response is to move your arms horizontally under the water, okay, to try to somewhat tread water. Mouth is usually barely out of the water. And when somebody tries to exhale air to shout or scream, that decreases their buoyancy. So they usually don't yell or scream. So the initial minutes of drowning, what happens? So usually there's a panic and a struggle. It's usually underwater, okay? Breath holding, and then they start swallowing water. And what happens is they only aspirate a small amount of water during this time period. And they aspirate a small amount, and then they get laryngospasm. And that laryngospasm causes the hypoxia and hypercapnia. And then that progresses and they become unconscious. Eventually, over time, the larynx will relax, fluid will be aspirated into the lungs, further hypoxia, then they develop a mixed metabolic and respiratory acidosis. So it was once thought that drowning patients aspirate a lot of fluid, but I think recent studies and have shown that they don't aspirate as much fluid as what we initially thought. So the fluid aspirated in the lungs is only thought to be 3 to 4 mils per kilo. So it's not actually that much fluid that they aspirate. You also have to think about the fluid they do aspirate. Depending on where they drown, it may be contaminated sand, mud, vomit, or other debris. So you also have to think about the type of fluid they do aspirate. So I'm going to go system by system and talk a little bit about what happens during drowning. So initially you get a sympathetic activation of the sympathetic nervous system. So you get initial hypertension and tachycardia. And then as you progress to worsening hypoxia, acidosis, and hypothermia, you get bradycardia, pulmonary hypertension, eventually decreased cardiac output. You progress to PEA, and then asystole is the normal progression. So this is important with rescue resuscitation efforts. This is when we'll talk about this a little bit later. But the presence of an initiable shockable rhythm, this is when you hook them up to when EMS gets there at all, is VTAC or VFib, is only found in less than 5% of patients. So this is different than the adult that passes out, becomes unconscious, you hook them up to the AED, and a lot of times they'll have a shockable rhythm. This is completely different, okay? So most patients do not have an initial shockable rhythm. Most of them go into PEA and then asystole. So this is important to know with resuscitation, and we'll talk about that. Respiratory, the aspirated fluid causes washout, dysfunction of the surfactant. That causes atelectasis, decreased lung compliance, ventilation perfusion mismatch, intrapulmonary shunting. You can also get pulmonary edema from the increased capillary permeability, aspiration, and then myocardial failure. Up to 70% of the symptomatic survivors, so these are patients that are symptomatic, not the asymptomatic ones, develop acute lung injury and ARDS. Neurological. Neurological is the big one. Okay, we can usually support the lungs, but neurologic is the problem. and it's the hypoxic brain injury that causes the most morbidity and mortality. It's the leading cause of morbidity and mortality. It usually begins within 5 minutes of inadequate cerebral oxygenation. You can get all kinds of symptoms at the scene, all the way from confusion, disorientation, cerebral edema. A lot of these patients, if they have a severe anoxic event, they'll develop cerebral edema. They can be comatose. Seizures can develop very early on, and of course death also. Fluid and electrolytes, they used to think that it varied depending on if you drown in fresh water versus salt water. Okay, and we have a lot of saltwater pools now. I know we don't have an ocean nearby, but so fresh water is what they thought is you aspirate all this fresh water, and they felt like the water moved into the capillaries and actually caused a systemic hemodilution and hyponatremia is what was initially thought to happen. And then salt water, they felt like that the water moves from the plasma into the alveoli. These patients had more pulmonary edema, hypernatremia, hypovolemia. But they found that these studies mainly happened in animals and dogs. It does not happen so much in humans, and the reason is they don't aspirate that much water. Okay, so they don't aspirate a big enough volume to actually cause these fluid shifts. So these shifts are actually rarely seen in humans. Infections. Aspirated fluid may lead to infections up to 50% of victims. You want to inquire about the water source. What did they aspirate? Was it a pool? Was it the ocean? Or was it a drainage ditch that had all kind of stuff in it? No prophylaxis is indicated in the majority of patients. We usually don't prophylax them with antibiotics unless you know that they drown in contaminated water of some sort. So we'll talk about rescue and resuscitation, which is a very important part. The first seconds, I think, after you find a patient, what happens on the scene is very, very important. So rapid rescue is essential to survival. So they even knew this in 1814, okay, that it was very important to get to the patient as soon as you can. So the main goal is to restore oxygenation and ventilation. That is number one, because that's what happens to these patients. They're hypoxic. And then you want to restore perfusion also. So first of all, you want to give 5 rescue breaths, and that's even recommended to give in the water if needed. So it depends on where this patient is. If the patient's in the pool, or if they're in a river, or if they're in the ocean, or in a lake or somewhere, they're recommended you give those first 5 rescue breaths as soon as possible. So if you need to give it in the water while the patient's still in the water, give it in the water, okay? And it says you may need a higher inflation pressure too, because the surfactant washes out and it decreases your lung compliance. So you may have to give a higher inflation pressure. But those first 5 rescue breaths are of huge importance. So that being said, compression-only CPR is not appropriate. So a lot of studies and all are going to compression-only CPR. These are not drowning patients. These are patients that have some oxygen still dissolved in their blood, okay, that can do compression-only CPR. These patients are hypoxemic, and that's why they actually arrest. Okay, so compression-only CPR is not appropriate for a drowning patient. So you want to give those 5 rescue breaths, start CPR, then call EMS. The 5 rescue breaths, I think, are the most important. And then at some point, place an AED. Like I said, less than 5% of patients actually have an initial shockable rhythm. So that's kind of down your protocol a little bit compared to a, out of hospital cardiac arrest for adult patient. Okay, what do you do in the ER, in the emergency department? You're going to optimize oxygenation. Like I said, that's number 1. Maintain their cardiac output. Temperature control, you want to active rewarm them to 34 degrees, and we'll talk about that also in a minute. Stabilize C-spine, and if there's a history or exam suggestive of neck injury. So they've noticed that C-spine injuries are only present, and it's as low as 0.5% of patients. And those 0.5% of patients that do have a C-spine injury, they either have a history or they have trauma or evidence that they have a C-spine injury, as far as facial trauma and things like that. So the majority of patients do not have a C-spine injury. So the intensive care, you want to treat the hypoxia. You can use non-invasive if the patient's awake, mechanical ventilation. Some people have tried to use surfactant therapy because they aspirate this water, causes disruption of the surfactant. but that has not actually proven to be of benefit, so it is not standard of care at this point. Of course, ECMO, if you have refractory hypoxia, so ECMO is good for that. Also, if you have severe hypothermia, and we don't have a whole lot of that around here because we don't live in a cold climate, but especially like up north, you know, where patients come in, they're very, very cold, you can use ECMO to rapidly rewarm them, okay? At least to a normal temperature or close to normal temperature. You also want to maintain cardiovascular stability. Neuro Protection, you want to prevent that secondary brain injury. Okay, they've already had an initial hypoxic insult, so you want to prevent the secondary injury. Maintain normal O2, blood pressure, glucose. Avoid hyperthermia and seizures. And there's actually no evidence out there to support hypothermia. And there's been a lot of recent stuff lately about hypothermia and peds, and that's a whole nother lecture right there. But we do know that hyperthermia, the patient gets fever and seizures, both of that is harmful to the patient, and they do worse. So you want to avoid hyperthermia and seizures. So there's no evidence to support barbiturates, no evidence to support ICP monitoring, even when there's evidence of cerebral edema. Invasive ICP monitoring does not shown to improve outcome. Steroids does not improve outcome. Prophylactic antibiotics do not improve outcome. Like I said, unless they develop a pneumonia later down the road, or you know they have contaminated water. So prognosis and outcome. Number one is the duration of anoxia. How long were they down? How long did the brain not get oxygen? Okay. So the problem is the time of recognition of drowning to the start of CPR. So, you know, we get a lot of estimates. Well, the patient was in the water maybe 5 minutes. The patient was in the water like 10 minutes. The real time is how long were they submerged, plus when was the onset of CPR started. That's the real time that you want to know, okay? Because some people, you know, will pull them out of the water, they don't know CPR, they'll wait for EMS to get there. I mean, that's precious minutes that are, you know, critical minutes that are wasted. So you really, your submersion, it's not just it's your submersion time plus the onset of CPR. A lot of times it's overestimated, a lot of times it's underestimated. It's very difficult to get a good estimate of the scene. Whether or not it was a witnessed event, if somebody was there, or if they were just found in the pool. If it was a water rescue, makes a difference too. If they're out in the middle of a lake, you know, and you've got to take a boat out to go get them, or, you know, you got to think about that, versus a swimming pool where they're right there and the parent, you know, is right there. The other thing is bystander CPR versus EMS. You know, if there is somebody there on the scene that knows how to do CPR and can initiate CPR, like I said, those seconds, those minutes are very critical because it takes EMS time to get there. You know, with the rescue breaths given in the water. The presence of respiratory or cardiac arrest. So when you pull the patient out of the water, are they spontaneously breathing? Do they breathe on their own? Do they have a pulse, or do they have cardiac arrest? So it varies your prognosis. Okay, if they just have respiratory arrest, those are going to do better. You know, if they still have a pulse, those patients are going to do better and have a better outcome than those that have respiratory and cardiac arrest. Okay, at the scene. Also, their initial GCS will tell about prognosis. Poor outcome indicators. Okay, so nobody knows a real time. Okay, like, oh, you were in the water this long, or it was this long before CPR was started, or whatever. But these are just some general things that they've come up with looking at the studies and all. Submersion greater than 25 minutes is not good. Okay, CPR greater than 25 minutes, not good. They've also found that hypothermia on arrival to the ER is not good. Okay, so if you're still hypothermic when you get to the ER, that is shown to be a poor prognosis. Fixed and dilated pupils, pH less than 7. If you're apneic on the arrival to the ER, that's bad. GCS 3 only localizes to pain at 24 hours. If you have no other neurologic recovery, that's not good. And if you have abnormal CT at 36 hours, that's also not good. Usually it's cerebral edema. So is cold water protective? So we always hear about these people that fall into the, of course it's not around here, we don't have winter, okay? But up north, they fall through the ice, they're submerged for a prolonged period of time, and they end up being great. They end up being fine, neurologically intact, no problems. And these are actually, you know, whether it's neuroprotective or not, there's been several studies that have been done. And it's actually based on a few case reports, okay, a few case reports of these. And it's actually very, very cold water. So it's not what's around here. Even if somebody falls in the pool around here in the middle of winter, it's still not cold enough. It's usually less than 10 degrees Celsius, most of the time less than 6 degrees. What is thought to happen is what they think is it elicits the diving reflex, okay? What the diving reflex is when your face is submerged in cold water. This is for mammals, all mammals. Face is submerged in cold water. It induces a bradycardia and causes peripheral vasoconstriction. So what it does is it shunts blood primarily to the brain and the heart, okay? It allows mammals to survive underwater with less oxygen because it's shunting your blood centrally. So it is felt to be great for other mammals who live in the water. Humans, it's not so significant. We're not as effective, okay? And it's felt to be very transient. The other thing is your face has to be submerged in the cold water. They've actually put people in the water with their face not submerged, just their extremities, and they don't elicit the diving response. So very interesting. So this is thought to not be that significant in humans. So multiple studies have looked at patients up north where they've looked at the temperature of the water, and they have not proven to have neuroprotective effects, despite these few case reports. And they've actually shown that hypothermia on arrival to the ER is a poor prognostic indicator. The other thing is hypothermia protection is thought to be dependent on the slowing of cerebral metabolism before the hypoxemic injury. So it only occurs in the most frigid water, and it only happens when the victim remains above water for a time while being cooled. So they're actually cooled before their hypoxemic insult, which rarely happens, because usually they become hypoxemic first. Neurologic outcomes, like I said, this is the #1 cause of morbidity and mortality in patients, is the hypoxemic event. There's a very wide range that occurs, and it's dependent on the duration of hypoxia. The most susceptible areas of the brain are the vascular end zones, the hippocampus, the insular cortex, and the basal ganglia. Of course, like I said, if you have a history of a cardiac arrest at the scene or in the ER, you have an unfavorable outcome. So hypoxic brain injury usually see problems with memory, impaired executive functions, visuospatial, visual perceptual performance. You can also have MRI be normal in patients with deficits. So they've showed a lot of patients who are discharged from the hospital after their event have a normal MRI, are functioning at age, seem to be functioning at age related, but then actually do have deficits and problems later on. And it's been shown that the strongest improvement is during the first year after the event. That's what we tell all our traumatic brain injury patients too, is most of your improvement is going to be the first year. At 1 year, then you'll see where you're going to be. Repeated clinical neurologic exams is actually the most accurate early in the course for predicting outcome. So just plain clinical neurologic exams, not MRI, not CT, just neurological exams is the best predictor. It's difficult to measure and access in PEDS patients. You know, it's hard to measure, you know, the neurocognitive and all the different outcomes. You know, it's hard to find a test to measure that, especially in the younger patients. You know, the biggest age group is 1 to 4, so it's hard to measure any deficits. Most victims are not at school age. So a lot of sequelae, the patients are seen, have a normal MRI, seem to be age appropriate, discharged home, and then their sequelae may not manifest until they enter school and they start having some learning disability, learning problems, or even up to early adolescence. And that may be tied to their drowning incident early on when they were younger. So prevention, this is a big one. Multi-layer protection. So there's not one thing that's going to prevent a patient from drowning, okay? Up to 85% of drownings are thought to be preventable, which is a huge amount. One of the biggest things is supervision. So, you know, we see people out at the pool all the time. They're sitting there watching their kids, but are they really watching their kids? No, they're talking on their cell phone, they're reading a book. So you're supposed to limit distractions. If you're the one watching the kids, you should be focused on watching the kids. Touch supervision is what's recommended for toddlers. So the toddler age group, touch supervision means that the toddler should be within arm's length of you at all times. So you should be within arm's length because the toddlers are quick. The other thing is appropriate supervisor. So the patient that is designated to supervise, those people need to know how to swim, how to do CPR would be nice, but they at least need to know how to swim, have a phone available to call for help, things like that. We did have a patient a couple of years ago in PI that they were allowing to swim. They got grandpa to watch the child, but grandpa did not know how to swim. So the child went under. Grandpa had to run next door to get help. Could not rescue the child. So you have to watch of who the supervisor is watching the kids. Okay, a lot of people don't think about that. Oh, you watch the kids, but if they can't swim, it does not help a whole lot. Swimming skills begin at age 4. The AAP recommends, of course, it's individualized about when a child is able to start swimming lessons. Every child is different, but they really recommend around age 4. You got to be careful with having child in swimming lessons because it can give parents a false sense of security. Oh, my patient can swim. My child can swim. I don't have to worry about them. I don't have to watch them. And it also, you have to be careful of the younger age group. It reduces their fear of water. Once they feel like they know how to swim or in swimming lessons or start to be around water, it reduces their fear, so they'll just walk on in the water. Another thing is learning CPR. The general public to learn CPR for those first, the rescue efforts at the onset. Of course, wear life jackets, buddy system, teach older children, never swim alone, always have somebody with you. Air-filled and foam toys are not a substitute for a life jacket. You see a lot of kids at the pool with the air-inflated floaties and things like that. That is not recommended. Alcohol and drug use, especially in the teenagers. It's a big part in the teenagers. They go out with some friends, they're going to have alcohol, they're out swimming, things like that. Another recommendation is 4-sided fence around the pool. That is a huge one. 4-sided, all the way completely surrounded, not associated with a house. Pool covers, alarms, evidence is lacking. Gate must be self-latching, self-closing. It has supposed to be the fence is supposed to be appropriate height and climb resistant. Some people will put a fence around it, but it's a chain link fence, so you can climb it. The other thing is to clear the pool and deck of toys after you're done swimming, because what happens is a kid will see the toys around the pool, just sitting on the deck outside. They'll go for the toys and fall in the pool. Of course, when you're at the beach, obey the colored flags, beware of rip currents, teach your kids what to do if they're involved with the rip current. The other thing I thought was interesting, which I did not know before, seizure patients. So, of course, when they're young, you can supervise them, but when they get older, they're not going to want you in there with them, whether they're taking a bath or shower. So it recommends that all seizure patients need to take showers, not baths, because apparently the bathtub is one of the biggest places. So I did not realize that. So now you need to recommend all your seizure patients take showers, not baths.
Make sure they don't do like my child does, put the washcloth over the drain so that they end up with 2 inches of water at the bottom of the shower.
Okay. So that's something that y'all can do, with all the seizure, because we have a lot of seizure patients. Of course, bathtub. We just had the patient last night come in with the bathtub. Never leave young children alone. Oh, I'm going to step out just a minute, answer the phone or whatever, and leave my child 2 seconds in the bathtub. The other problem is leaving with a sibling when co-bathing. You leave an older sibling in there or something, they cannot be responsible. They are not an adult. Okay, so you can't leave 2 kids in the bathtub by themselves. And then there's a big thing, too, about the infant bath seats. A lot of people think they need to be banned. That is not a substitute for supervision. They've had reports of kids getting entrapped, tangled, all in the bath seats. Empty water from containers, buckets. Do not leave young children alone in the bathroom. There was some recent things about entrapment or entanglement of pool spas and drains of hair or body part entrapment. So they have drain covers, filter pumps, and things with that. So you got to be careful with that, especially if you have a home pool or spa. They try to teach too first entry into a body of water. So especially if it's not a pool and you don't know the depth. If you're, teach the adolescents, if they're out, swimming in a lake or something, first entry should be jump into the water first, feet first. Don't dive into something you don't know how deep it is. And the other thing they recommend is swimming in areas patrolled by lifeguards. Okay, role of the pediatrician. So what can we do as we see patients in our office, primary care, as far as prevention? If 80 to 85% of these deaths are preventable, what can we do in the office? So in 1994, there was a survey done that I thought was quite interesting by the AAP Committee on Injury and Poison Prevention. And what they did is they did mail-out surveys to pediatricians in practice. And they looked at pediatricians, their experience with treating drowning patients, the water safety counseling practices that they did, and their attitude toward drowning prevention legislation. And they had 1,117 completed questionnaires and a response rate of 68.9%. So pediatricians' experience. So about a quarter of them had treated or counseled victims of drowning. So that's quite a bit of pediatricians. 51% were in the 1 to 4 year old category, which goes along with where the main drowning victims occur. 23% less than 1 year, 5% were adolescents. And then as far as sequelae, do they have sequelae from their event? 42% had none, 31% had neurologic deficiency, and 22% of them died. Location kind of goes along with the data also. 59% were in the pool, 38% were in open water, 28% were the bathtub, sink, or toilet. Calls, 84% was lack of supervision, so nobody was around. 28% lack of a four-sided fence, 23% was an open pool gate. So they had a fence around, but the pool gate was left open. So the prevention counseling, what was interesting to me, and this is what they actually did in their practice, 83% of pediatricians talked to parents about toddlers 1 to 4 year old. 83% discussed safety issues, water safety. 69% less than a year in the 5 to 12 year, and then 44% talked to adolescents. You got to remember to talk to the adolescents about this too. Only 12% routinely identified families with a pool. So how many of y'all actually ask your patients, do y'all have a pool at home? Okay. 30% always recommended a four-side fence. 22% always recommended CPR. Have you ever referred, okay, you have a pool, you need to know how to do CPR, okay? Not just your own kids. You have a pool, you're gonna have other kids over at your house too. 63% sometimes recommended it, and 15% never do. So you need to think about water safety in your prevention counseling. Legislation, 4% of pediatricians are actually active in promoting legislation. 96% felt like there should be laws requiring fencing around pools. There are laws as far as fencing, mainly in-ground pools. I think the problem is there's not a whole lot of laws as far as above-ground pools. And there's a lot of inflatable pools, above-ground pools that can hold a lot of water and that people leave water in. And so that's been an issue, and those don't require fencing. 91% of pediatricians should feel like there should be laws requiring children less than 12 to wear life jackets on boats. So in conclusion, talked about the national worldwide statistics of drowning. Remember, it's the second leading cause of death from unintentional injury in the U.S. in ages 1 to 19. We talked about the risk factors, males, toddlers, minorities, and underlying seizure disorder. Don't forget your seizure patients. We talked about the pathophysiology of drowning, silent, okay? Patients usually don't yell they're in trouble. Panic, breath holding, laryngospasm, hypoxemia, loss of consciousness, and they only usually aspirate a small amount of fluid. The predictors of outcome of drowning, usually the duration of submersion and the initial resuscitation. So the time from submersion to the beginning onset of CPR. Explore the role of the pediatrician. What can we do in our office to help prevent? 80 to 85% of them can be prevented. So what can we do? Counseling, pool, four-sided fence, CPR, life jackets, no alcohol. Talk to your patients about their exposure to water. and maybe participate in legislation to prevent drowning. So I found a quote here, Robert Bly, whenever there is water, there is someone drowning. Okay, do y'all have questions?
Rebecca, in the drownings with the pools, a lot of people for their toddlers will get these, short, maybe several feet across pools to have in the backyard or something. I understand the issue of drowning in buckets, toilets, things like that, where they fall in and head forward and can't get out. But when they talk about pools, did they look, is there drowning in those little pools versus the big ones that, adults can swim in?
Yeah, I mean, they recommend
even
the inflatable pools is a big issue because people will fill it and let the kids play, and then they go in for nap time or whatever, and then the kids will get back out in the pool without anybody, it doesn't take much water,
Right.
for them to drown. So it is a problem because you're supposed to empty the water out. As soon as you're done using it, you're supposed to empty the water out. And
Right, but I don't actually know how many inflatable pools are around now versus these hard-sided ones. You know what I'm talking about? That's what I was curious
even the
about.
hard-sided ones, they say that even though they're hard-sided, the kids still, will get up there, they'll fall in, they're up there looking over.
No, I'm just talking about the short little ones.
Yeah, the same thing.
The little wading pools.
Yeah, they're still a big danger for people that leave water in them. I mean, it's recommended, that you can have them and use them supervised, and then you empty the water out as soon as you're done.
Right,
Because it's still like a bucket sitting around.
okay.
I can't remember the number, but there is, for those little inflatable pools, I think you only need like 6 or 8 inches of water in it for a young infant, a child under 18 months of age to drown in.
It's a very small
I
amount.
think when they fall in, they don't know that they need to sit up to get out of the water.
Yeah.
And so that's a real challenge, and that's why I think, as Rebecca said, supervision and then emptying that pool out, turning it over when you're done so that nobody can get back in it, I think really important.
I was just curious if there was a breakdown in statistics
Oh.
between the bigger pools and
I
those
didn't see any breakdown
little
as far
ones.
as,
So,
You would think if they're over 3 or 4, the likelihood of drowning in a wading pool goes down.
Oh,
Yeah, it does.
Yeah. Yeah.
Rebecca, does the Academy of Pediatrics or any other organizations have posters available that can be put into pediatricians' offices, sort of if you own a pool, these are the things to think about?
I looked on the AAP website. They have some guidelines that are, I think they did 2002 and 2012. They updated some guidelines. I didn't see any posters or anything, or any handout. I'm not sure about that. But they do have some printed guidelines and suggestions.
So-
Actually, the CDC the CDC website had a good thing about prevention.
So if maybe a couple of our students who are on peds rotation, if you want to take what Rebecca's told us about and make a poster that could be used in the pediatrician's office, we can get the Academy of Pediatrics local chapter or state chapter to print 1,000 and get them out. Just, simple. If you own a pool, are these things in place? And that'll be your homework before you finish your rotation. Maybe Rebecca will review it and we'll get it done. Okay?
I think the Red Cross,
Yeah.
I think the Red Cross put out
So
a
what's
poster.
available, but let's do
I think they put out a poster this last summer that was supposed to be posted, especially at like community pools and stuff, but I think there was some controversy. So I think it got recalled. I don't know if they redid another one, but, yeah. Yeah. So,
Well, and speaking to that too, someone asked why there seem to be more African Americans who can't swim. And part of that is culturally, with segregation, African Americans weren't allowed in the pools. And so you didn't have, so there weren't places to have swimming lessons. It was a lake and a river. And so you have generations of people that were not able to, they never learned how to swim. The other thing is that it's expensive swimming lessons, although the Y of the new bulletin is supposed to have every second grader in Caterpillar schools come through the pool. I'm not sure exactly, they're not teaching lessons, but I know they're doing water safety, I'm not sure what else, but they've categories provided buses, so I'm not sure exactly what all that's doing.
The other thing I found about minorities is, a lot of the Caucasian children are exposed to pools, home pools, friends pools, things a lot earlier in life, and so that 1 to 4 year age, whereas minorities are usually not exposed to pools until teenage years. Then you have peer pressure, and everybody else can swim, and you say, oh, I can swim too, and then you get into situations that you think you can swim and you can't, and so they end up in a lot more dangerous situations, I think. But they're not exposed actually to pools till later, and so I think that's why their risk of drowning deaths is a little bit higher in the teenage years than they are than the younger kids.
Knowing who is watching your children is very important, because like you said, the grandpa that can't swim, my in-laws have a pool and my kids swim out there, and even though both of my in-laws are scuba divers, I don't know that they're healthy and strong enough to pull either of my children up off the bottom of the pool. So last summer, I had my kids go to swimming lessons, and their lesson was how to pull somebody else off the bottom of the pool. And they were told specifically, you are the strongest ones at this pool. You need to know how to rescue somebody. And so they've actually had pool safety and rescue lessons, because they're in a situation where I don't know if the grown-up watching them can pull them off the bottom of the pool.
My mother-in-law was furious at me for a whole summer when we first moved to our house with the pool, because my mother-in-law cannot swim, and she would keep my kids during the summer while I was working, and she could not understand why I would not let the kids get in the pool when I was not there, and she was watching the kids, but she can't swim. So I'm like, absolutely not. But she was furious with me the whole summer. I was like, oh, well. But she was like, I don't understand. Why can't they swim? I could, help them or whatever. And I'm like, no, there is a deep end, and no, you cannot swim, so no. So she was just mad, and she got over it. It was okay. My kids are safe.
She had to learn to swim.
Yeah.
Swim.
Mm-hmm. I was like, sorry.
Did you see anything on infant rescue swim that's teaching like toddlers?
So the AAP is not a fan of that at all. They said that it is, they're not old enough to actually know how to do that, and they are not a big fan of that as far as the AAP recommendations. They're saying age 4 and up. They said maybe age 1 to 4, maybe, that's the biggest, highest risk of drowning, but then they say, it gives parents a false sense of security, it makes them where they're not afraid of water, it's kind of a double-edged sword. But they do not agree with the rest, the videos of kids online, you can see the babies and the AAP does not agree with that at all.
Going back 50 years, we were taught something called artificial respiration, which was basically seemed to have the emphasis on, one, inflating the lungs, but also removing water from them. Now, what's the status of that compared to modern methods?
Out of favor.
Out of favor, okay.
Because I did see that. They talked about there was a big push on, you've got to get the water out of the lungs. So you'd actually turn the patient over and do actually compressions on the back, trying to get the water out. But I think the big thing is there's not that much water that's aspirated. So there's not that much quote unquote water in the lungs to get out.
That's not the problem.
Right, and so it's not the main problem. And so they recommend against that.
It was also widely taught that if you ate, you had to wait half an hour or an hour before going in the water in order to avoid stomach cramps. So if you're drowning, is that still considered important?
No. That's old school too. Yeah.
Kept you out of the water a lot. All right, well, this is a great presentation, Rebecca, thank you. I think this is something that you need to take back to the office and use every day when you do anticipatory guidance, because as Rebecca said, from bathing, an infant all the way up through it, and a teenager, first time in the pool, this applies. And so it's really an important aspect of preventive medicine, anticipatory guidance. So this is really important. So thank you, Rebecca. Appreciate it.